Okay guys, today we are going to talk about the bronchial asthma. So what is a bronchial asthma? It's a tracheobronchial tree constriction. And one of the main thing we have to understand is reversible. On the other hand, COPD is irreversible. We're gonna discuss about the COPD in the next video with fully details. So for asthma, you need some kind of a trigger to start these things. So let's go allergic. You need a stimulate, and we divide it into two parts: intrinsic and extrinsic. So extrinsic we're going to talk about today. So let's see here, 90% by pollen, dust, fumes, pores, they trigger this asthma. Okay, and most of the occupational occupational reason to affect this asthma, like for example a person is working on the resins factory, fiber factory, or silicon factory, and the dust goes inside to his lungs, it's gonna trigger this extrinsic asthma. Etiology is really simple. It's epidemiological trait. What is epidemiological trait is like agents goes to the host, host to the environment, environment to the host. It's like a triangle. We have to simple understand this thing, epidemiological trait. And one of the main thing here, human leukocyte antigen is HLA-DR1 gene. This is the main key point. What is here play an important role for this asthma here. And this one only present on antigen presenting cells. And what test we have to give to the patient to understand if he has asthma or not is called pulmonary function test. So here we have to understand like a FEV or FVO. So we have to understand this. It is really important. But before we go there, we have to understand this. Pathogenesis. Pathogenesis for extrinsic asthma. And there's a key point about the PMC exam. What kind of hypersensitivity it can cause? Type 1 hypersensitivity reaction. So now we see here, here we can see dust exposed. When the patient exposed to the dust goes to the to the macrophage in the lungs, and macrophage, what it's gonna do here, you can see human leukocyte antigen DR1. It's gonna release, and macrophages with the help of helper T cells is gonna release cytokine, and cytokine is gonna release interleukin 4, interleukin 5 release, and interleukin 5 effect on the B lymphocyte, and B lymphocyte is gonna release to the plasma cell, and plasma cell gonna release to the immunoglobulin E. And what is gonna do that hemoglobin E? Its antibodies bind with the mast cell, and mast cell just only with 25 to 30 minutes is gonna affect. And what is gonna happen? The mast cell attached with the antigen then release histamine. So this, you can see how the histamine release by exposing to the dust. So this is simple pathologies, and this, the one key point you have to understand, this only happens once in a life. If a patient has asthma, so this step is gonna happen just only once, and next time if he exposed to some dust particle or external factors, this step is not gonna be there. It's gonna be direct histamine release in the body. So histamine function is gonna do with the anaphylactic reactions. And what is the anaphylactic reaction? Bronchoconstriction, high production of mucus, vasodilation, and vascular permeability. And histamine removed by the histaminase lysosome within hour. So what does it mean by that? Like histamine, it can be released by itself. There is, as we can say, like a backup in our body. Histaminase lysosome can remove the histamine. So it shouldn't be give too much problem. But what the histamine do before histaminase remove the histamine, it's gonna activate phospholipase A2. And what the phospholipase 2 enzyme gonna do in the late phase, it's gonna break cell membrane phospholipase by active white blood cells. So what it's gonna do is gonna activate the white blood cells. That's, you can say, like a suicide bomb. Histamine is going to remove, but it activates this one, and this one activates what? White blood cells. And white blood cells, you can see here, the phospholipase release arachidonic acid metabolized by active white blood cells. So it can continue by 2 to 8 hours. Takes like a 2 to 8 hours for getting this step. Okay, so simple, you can see histamine, before it goes to die, it activates phospholipase A2, and phospholipase A2 with the help of white blood cell release arachidonic acid, and arachidonic acid release two things: lipooxygenase and cyclooxygenase. So first we discuss about lipooxygenase. Lipooxygenase release F5-HPET. It's an unstable product, and is gonna convert into leukotriene A4 immediately, and leukotriene A4 is gonna go to leukotriene C4, leukotriene D4, and leukotriene E4, and also is gonna go there with leukotriene B4, but mostly here you can see these all leukotrienes, what they're gonna do: bronchoconstriction, high mucus production, vasoconstriction, and one of the main thing, slow release substance of anaphylaxis. So this is the key point. Which of the leukotrienes are gonna release? This is A, you can say A4 or C4, D4, or E4. And one of the key point you have to understand, like lipooxygenase released by the lipooxygenase pathway, and cyclooxygenase we're gonna release by cyclooxygenase pathway. And what the cyclooxygenase is gonna do, you can see here, like it's gonna release prostaglandins, prostaglandin G2, H2. Prostaglandin H2, what is gonna do? Release white blood cells. Prostaglandin D2, prostaglandin E2, prostaglandin F alpha. And what they can cause? Pain, fever, high level of acids in our body. And what is going to affect on the platelets? It's going to platelets, what is going to do? Thromboxane A2 can cause thrombotic aggregations, vasoconstrictions. So here, endothelial cells, what's going to affect on with the prostaglandin I2, prostacyclin inhibit the platelets, cause vasodilations. See, inhibit the platelets cause vasodilation, and then here you can see vasoconstrictions. So this is its effect, but we can stop these things. We can stop everything by using the drugs. What here, the cyclooxygenase, we can use aspirin to reduce this effect. And what is the aspirin? Is non-steroidal drug. So we can see here non-inflammatory drugs. So we don't used to use steroids. We can use like a non-steroid inflammatory drugs like aspirin. And what the aspirin can do, analgesic effect, antiplatelet effect, antipyretal effect, the fever is gonna go down, but the side effect is here is gonna increase the acid in our body. And here, what about if we won't let our body to release arachidonic acid? What are you gonna do? We can stop this. We can stop this phospholipase A to produce by histamine. We can use steroids. Can inhibit this breakdown. This is the key point. Which kind of the exam, like which kind of the drugs we can use to inhibit this? We can say steroids. And now here's some key points, really important point you have to understand. Like extrinsic asthma is an inflammatory process, so drug of choice should be non-inflammatory. Why non-inflammatory? Because it's also causing inflammation in our body. You can see interleukins like a bronchoconstriction, mucus. So we have to use non-inflammatory drugs. Which kind of drugs? Interleukins, inhibitors. We can use these inhibitors to not let this happen in our body by montelukast and zafarlukast. And we can also use steroids, so optional choice. So guys, this is for today. We are for asthma, especially extrinsic asthma. So next we're gonna talk about intrinsic asthma. Okay.